Am I audible to everyone now? Still not. Okay. Bismillah ar-Rahman ar-Rahim. So, saving life of one is just like saving life of whole humanity. This is actually the motive of this conducting this workshop. So, this is the workshop where we will be dealing with the first hour or other golden hour management of trauma victims. I am Sabah Saqib. What we know about the advanced trauma life support, and then we will be dealing with the assessment of trauma in a simulated patient, which will be actually a case. Then we will be dealing how to do a primary survey in trauma, importance of resuscitation and re-evaluation. We will be quickly going through the videos of primary survey, and then we'll be dealing with the secondary survey. And then we will also be watching a video of secondary survey. And then the most important, last but not the least, that what is actually the need to transfer in a definite care. This is the situation which comes often when you are working in a rural health center or maybe a center remote to the tertiary care, and the victim often requires a higher level of trauma care. So what are the aims of trauma? Trauma, we all know, is the leading cause of death in younger patient. It actually causes significant disability and often loss of work hours. By this workshop, our aim is actually to learn the principles of advanced trauma life support, how and able to assess and prioritize the injuries in the trauma victims. Manage the trauma patients according to the facilities wherever you are working, and need to think that there is a need to transfer this patient to a higher level of trauma center. So these are actually the three major objectives of this workshop. So first we'll go quickly through the pre-test, that what we know about the trauma. For this you need to be connected with the Wi-Fi, which is auditorium, and the password which is written is THI12345. I hope you all have smartphones. So once you are connected, then we will be going through this pre-test. And once you are connected, then log into pollev.com/Sabahuddin SA500. This is the link where you will poll your answers. Maybe slow speed. Anyone who is connected, जो हो गया अभी तक? THI12345. This is the password of auditorium, and then you have to connect with this link, pollev.com/Sabahuddin SA500. इंटरनेट कनेक्शन थोड़ा सा स्लो हो गया. THI is all small, 1 2 3 4 5. THI 1 2 3 4 5. They are working on it. Maybe we'll be connected in a couple of minutes. They are working on it. नहीं अभी भी नहीं है। All small, THI 1 2 3 4 5. What? THI 1 2 3 4 5 what? वो तो पोल ईवी में लेके आता हूँ मैं आता हूँ। Just give us a time maybe. Not working. हो गया मेरा क्यों नहीं हो रहा? Auditorium connect. My own is not connected. It's not connected yet. कोई बात नहीं। Still not. Wait, we'll see, otherwise we'll go on. What do we have? आपने ओपन कर दिया क्या? ओपन कर दिया आपने?
नेट तो ओके है।
ओपन कर दिया आपने?
नहीं ओपन नहीं है।
वही कनेक्टेड। कनेक्ट मेरा ही कनेक्ट नहीं हो रहा, तो बाकी किसका होगा? Forget network. Auditorium. One, two, three, four, five. Yeah. Can't connect to this one. कुछ करना पड़ेगा।
ट्राई करना।
Auditorium. Connect. Checking network requirements. Auditorium में भी शायद आप कर दें। नहीं।
ये क्वेश्चन किस चीज़ का आ रहा है?
ये क्वेश्चन दूसरी का ही आ रहा है, नेट का ही आ रहा है। तो आपका ने यहाँ पर पासवर्ड चेंज किया है?
ये पासवर्ड तो वही है, पासवर्ड चेंज नहीं हुआ।
तो ये देखिए मेरा कनेक्ट किया।
ये देखिए ना इधर।
ऑडिटोरियम कनेक्ट। Still not working. Help me to solve. बाकियों का किसी का कनेक्ट हुआ है? बाकियों का Anyone who is connected with this Wi-Fi? No. So they are rebooting the Wi-Fi. Maybe after that we'll be able. Huh? You have with this password. So some are connected. Some are not. Connect automatically. Forget network, close, help me. Just give us 5 minutes, otherwise we'll go through quickly maybe, or you can poll directly with the interaction. कोई और पासवर्ड भी नहीं है, कोई और ईगो लगा दें यहाँ पे, उससे कनेक्ट कर दें एटलीस्ट फॉर द टाइमिंग, मेरा तो चले। नहीं हो रहा। Still not. अब कनेक्ट हुआ शायद। लोड ज़्यादा है तो ये लोड ज़्यादा है। I think internet is working but slow maybe, so we can skip this part. High expectation. One, two, three, four, five, 8. ये कनेक्ट तो हो गया। It's connected. Disconnect. लेकिन पासवर्ड दे मांगेगा ना। 1, 2, 3, 4, 5, 8 कर दिया आपने। हाँ ये करते हैं। हाँ पहले तो ये करना चाहिए था। वो मेरे पास 8 नहीं लिखा ना, आपने पासवर्ड चेंज किया नहीं हो रहा। चलो अच्छा वो ऑप्शन नहीं दे रहा। काम करते हैं, माइक दे दो और क्वेश्चंस कर देते हैं।
वैसे उसको फॉरगेट करना है, जब तक इसका पुराना पासवर्ड नहीं निकलेगा।
फॉरगेट आ ही नहीं रहा, ऑप्शन ही नहीं आ रहा।
उसकी रीज़न ये थी कि जो हमारे लिस्ट है ना, वो 30 क्लाइंट कनेक्ट हो चुके थे, इसके लिए जगह नहीं बची।
लेकिन नहीं, मैं पहले कनेक्टेड था, मैं तो डिलीट कैसे हो गया ये सोचे ना, तो कनेक्टेड था। इस पासवर्ड से फॉरगेट कैसे करना है? शुक्र सर, इससे फॉरगेट कैसे करना है? फॉरगेट करने का ऑप्शन बता। इसको नेटवर्क पे जाए।
पासवर्ड होता है एक जगह पे।
चलिए काम करें इनको।
नहीं ना सर, ये डिलीट नहीं हो सकता ना, इसके ड्राइवर उड़ जाने हैं। ड्राइवर्स कहाँ से इंस्टॉल करते हैं अपने दोबारा से सेटअप या अपग्रेड करते हैं।
चलो देखते हैं, नहीं होता तो बस इसको ख़त्म करते हैं, स्मार्ट को इतनी देर तक तो नहीं हो सकते हैं।
यहाँ सेटअप मैनेज
कोई बात नहीं,
ये प्रेजेंटेशन दूसरे लैपटॉप पे कॉपी कर देना।
नहीं वो चलेगा नहीं, सॉफ्टवेयर में चलेगा।
10 में है ना
ऑल्टोरियम THI 1 2 3 4 यहाँ पे कोई
नहीं,
वो भी नहीं
1 2 3 4 5 6 7 8 कर अभी चेंज करें क्योंकि आपकी लिस्ट कंप्लीट है।
है। मसला ये कि यहाँ से भी अब कनेक्ट नहीं हो रहा, इसको अब मैं कहाँ से उड़ाऊँ?
स्पेस नहीं बढ़ आपके लैपटॉप के लिए।
ब्रॉडबैंड कनेक्शन नहीं है। नहीं वो तो ठीक है, लेकिन 30 यूज़र मेरा तो पहले से कनेक्टेड था, मेरा डिलीट कैसे हो गया? ये समझ नहीं मेरी बात।
यहाँ पे फॉरगेट की ऑप्शन आती है,
वो अब नहीं आ रही। हमारे पास कोई ईगो भी नहीं है कि मैं ईगो से कनेक्ट नहीं होता। चले ठीक है, माइक दे दें कुछ ऐसे। Unfortunately, we had to skip this part, so we have no reason. Sorry for that. We tried our level best to make sure, but unfortunately couldn't. Okay, anyways, this pre-test I would skip. Yes, you can think here. Sare pass. So what we will be dealing with this patient. So this is a case scenario. A 30-year-old male. He's an unrestrained car driver. He had head-on collision with a trawler. He ejected and brought by 1122. Patient क्या है भाई इनका? So मेरे पास डॉक्टर नुमान है इमरजेंसी सर्विस के अंदर। वो आपको डेमोन्स्ट्रेशन करने की कोशिश करेंगे ऐसे जो इनके पास अवेलेबल फैसिलिटीज़ हैं कि वो कितना रिस्पॉन्ड कर सकें. कपड़ा हटा दो. स्क्रीन इज़ नॉट ओके, ये वाली. सो मे बी वो शायद हेल्प कर सकें. सो एनीवेज, डॉक्टर नुमान, सो डॉक्टर नुमान 30 साल का लड़का है, अनरिस्टेन्ड है, ट्रॉलर ने हिट किया है, एजेक्ट हो गया. जो 1122 ने इन्फॉर्मेशन दी है वो ये कि लड़का अनरिस्पॉन्सिव था, उसका हार्ट रेट 142 है, ब्लड प्रेशर 90/60 है, रिस्पायरेटरी रेट 40 है, सैचुरेशन इसकी 80% है, 88% है. इसकी एक डिफॉर्म राइट थाई है, एक बड़ा सा ब्रूज है चेस्ट पर. इसको जो एम्बुलेंस सर्विसेज प्रोवाइड की हुई है कि फेस मास्क लगा दिया है, उसको ऑक्सीजन से मिल रही है, उसको सर्वाइकल कॉलर अप्लाई कर दिया है. तो आप तैयार हैं इस मरीज़ को ऑपरेट करने के लिए?
सर मेरी ड्यूटी आप हो रही है, मैंने जाना था, काम है एक. अगर
मरीज
पेशेंट सीरियस है,
लेकिन नुमान वो मरीज़ 1122 वाले कह रहे हैं कि मरीज़ अब बस आ रहा है, ऑन द अराइवल है.
हम शायद इसको मैनेज ना कर सकें. अगर आप इसको
लेकिन आप उनको शुरू की केयर तो दे सकती हैं, थोड़ी सी देख लें अगर आप.
सर नहीं ठीक है, जब पेशेंट आए मुझे इन्फॉर्म कर दीजिए.
चलिए तो नुमान, पेशेंट आपका आ गया है, आपका पेशेंट है, मैनेज करें आप. आपको क्या क्या चाहिए, जो चीज़ें डॉक्टर हमाद हैं आपके साथ, वो आपको हेल्प करेंगे. डॉक्टर नुमान काफ़ी ये सिक पेशेंट लग रहा है, 140 का हार्ट रेट है, हाइपरटेंसिव भी हो रहा है. ये अच्छा कर रहे हैं आप सेफ्टी में, लेकिन थोड़ा सा क्विक कर लें मे बी. चलें 150 हो गया हार्ट रेट. कुछ करेंगे डॉक्टर नुमान के लिए? पेशेंट सैचुरेशन मजीद ड्रॉप कर रहा है, 80 हो गई है सैचुरेशन. नहीं कोई रिस्पांस नहीं है. 5 लीटर पे ऑक्सीजन चल रही है डॉक्टर नुमान. 10 पे कर दीजिए ऑक्सीजन. नहीं कोई रिस्पांस नहीं है, जीरो रिस्पांस डॉक्टर नुमान. या हाइपर बीपी के लगा दीजिए, बीपी 60/40 डॉक्टर नुमान, 60/40 ब्लड प्रेशर है. आईवी लाइन लगा दीजिए प्लीज. आईवी लाइन है, आईवी लाइन लग गई जी. क्या लगाना है इससे? फ्लूइड लगाना है, रिंगर लैक्टेट लगा दीजिए जी, 1 लीटर फ्लूइड लगा दीजिए. डॉक्टर नुमान पेशेंट के प्रेशर्स ऊपर नहीं आ रहे हैं. चले हम एक्सरे टेस्ट को कॉल कर देते हैं जी. एक्सरे डिपार्टमेंट को एक्टिवेट कर दीजिए प्लीज. डॉक्टर नुमान पेशेंट डीसेट कर रहा है, ही इज ऑन 70% सैचुरेशन. इंट्यूबेशन का सवाल है, आपको क्या चाहिए? लैरिंजोस्कोप दे दीजिए जी भाई. डॉक्टर नुमान पेशेंट डिसाइड कर रहा है, मजीद हाइपोटेंसिव हो गया है. इट्स नाउ 50/30. इंट्यूबेशन ठीक है आपकी, फ्लूइड चल रहा है, 1 लीटर हमने चला दिया. डॉक्टर नुमान पेशेंट हाइपोटेंसिव हो रहा है. पेशेंट नाउ 40/20. थोड़ी सी सैचुरेशन बेहतर हुई है इंट्यूबेशन के बाद, 88% सैचुरेशन हो गई है. नहीं डॉक्टर नुमान पेशेंट खराब हो रहा है. कुछ और करना चाहेंगे? डॉक्टर नुमान पेशेंट ब्रेडी में जा रहा है. डॉक्टर नुमान ही इज गोइंग इनटू ब्रेडी, ही इज गोइंग टू अरेस्ट. आई थिंक ही इज इन asystole now and the patient is no more. Sorry, patient is there. Dr. Maan, so we lost the patient, a young guy, a precious life we have lost. What could Dr. Numan do differ in this scenario? Anyone has idea? Maybe कोई mic दे दें. कोई positives, कोई negatives, कुछ. We lost the patient unfortunately. Any volunteer? क्या मिस्टेक्स की डॉक्टर नुमान ने? या कोई पॉजिटिव्स बता दीजिए पहले.
प्रायोरिटाइज नहीं की उन्होंने मैनेजमेंट अपनी।
इंजरीज प्रायोरिटाइज नहीं की। कोई पॉजिटिव आपको दिखा इसमें?
उन्होंने अपने डिसइंफेक्शन के मेथड्स वगैरह वो
यूनिवर्सल प्रिकॉशंस मेजर्स लिए उन्होंने। डॉक्टर मान ने कैप गाउन ग्लव्स पहना, ये एक अच्छा स्टेप था। पॉजिटिव्स भी थे, कुछ और पॉजिटिव्स या कोई और नेगेटिव्स?
दो आईवी लाइन लेनी चाहिए थी और फ्लूइड को फास्ट करना चाहिए था।
2 आईवी लाइन लेनी चाहिए थी और फ्लूइड को फास्ट करना चाहिए था। सबसे एक और है कि ही वाज नॉट विलिंग टू स्टार्ट विद कि भाई मैं जाना है, मेरे पास काम है। सो उनको एक रश ट्रॉमा था जो उनको पता था प्रायोरिटाइज करना था। उन्होंने कहा कि मेरे पास काम है, मैं भी नहीं मैनेज कर सकता। सो ये उन्होंने बहुत से ड्रॉबैक्स किए। ये नीचे करते हैं। सो नाउ वी विल एक्चुअली गोइंग टू सी कि हाउ वी शुड प्रायोरिटाइज अ ट्रॉमा विक्टिम। We will learn this art of doing A, B, C, D, E, and then we later on we will have a right demonstration as well. Okay. So, जिस तरह आपने बताया, you have rightly identified that the sequence of priorities was not fine. इन्होंने intubate किया जो कि requirement थी मरीज में, but he intubated at very last. So he was looking all around body में trauma, chest देख लिया, लेकिन जो airway का control था, which is actually the essence in managing the trauma victims, वो सबसे आखिर में किया more or less. तो sequence of priorities missing था. Initially assessment उनकी सही नहीं थी. जो उनको expectations थी injuries की वो उतनी नहीं थी. उनकी शायद expectations से ज़्यादा injuries थी. और in the end the patient lost his life, which is actually the end point, which is actually a shameful measure कि एक young लड़का था, he lost his life, 30-year gentleman, which could have been saved, or actually which could have been stabilized in इतना के he could have been sent into a trauma center, level 1 trauma center. So objectives भी इस workshop के यही हैं basically to identify the correct sequence of priorities in multiple injured patient. Will learn the art how to do a primary survey and then perform a secondary survey, and actually identify the need to transfer, when you need to transfer the trauma victim to a level 1 trauma center. So ये इन्होंने दी. Standard precautions were there, yes, I agree. Cap पहना हुआ था, gown पहना हुआ था, mask पहना हुआ था, shoe covers, protective measures जितनी वो ले सकते थे, जितनी उनके पास थी उन्होंने ली. So whenever you are assessing a trauma victim, you first have to protect yourself. You need to think कि भाई environment is clear, you are actually protective. So this is the one step that you need to take first. Concepts क्या है initial assessment का, जो कि ये नहीं कर पा रहे थे. He was unable to do a primary survey. और उसके जो basic adjuncts होते हैं, उन्होंने सिर्फ एक ही adjunct मांगा जो कि chest X-ray था. वो भी जब उनको मांगा जब उनको bruise मिला. So there are lots of adjuncts which we learn what are these adjuncts and why they are necessary to perform. And the second point which is very important, re-evaluation. I was giving him clues कि blood pressure down हो रहे हैं, heart rate down हो रहा है, but whatever he was taking measure कि drip चलाई है, ना वो पूछ रहा था, he was not asking, he was just thinking कि बस time निकालना है. So he was not actually re-evaluating patients. So whenever you are doing any intervention in the trauma, whatsoever it is, maybe it's an ETT tube, maybe it's passing an oral airway, maybe it's passing just a cannula and running a fluid, what you all need to do is to re-evaluate your patient. So this is very important skill, this is very important thing, because this will tell you that whether your intervention are working or not, whether it's going to affect your patient or whether you will be able to save your life or not. Secondary survey इतना time ही नहीं मिला, patient crash कर गया, but it is very important which we will learn that how to perform a secondary survey and its adjuncts in the setting of trauma. And he never bothered about that need to transfer a definite care. He was working in a rural health center, but the trauma victim was much more severe. This trauma was severe in intensity. He never think about कि ये patient he will not able to manage. So what his priority should have been, maybe stabilize करता, maybe इसको सोचता कि मैं इसको कहाँ पे shift कर सकता हूँ, transfer कर सकता हूँ, at least in such a setting where these facilities are available, where a chest surgeon is available, where whatever the injuries he has identified, वो pick कर सके. So whenever you are assessing a trauma victim, what you have to do is to correctly perform a primary survey and do its adjuncts. What are these adjuncts? We will see when we will be going through this demonstration, and we will actually perform the right way as well. And the second important thing is that in assessing trauma patient, you have to reevaluate all your interventions. And once you are done with the primary survey and reevaluation, then you can go into the secondary survey. And then you do the adjuncts of secondary survey. What are these? We will go through and we'll see each and every adjunct in detail. And while you are performing or managing a trauma patient, even in between them, even in the primary survey and secondary survey, your eyes will stick on a point that whether I will be able to provide a definite care or not in my setting, whether those facilities which are required to this patient are available in my care, in my center. If they are not available, then you need to contact with someone who can manage, who can provide a definite care to this patient. So this is very important. These are the three fundamental steps which you should perform, which you should know whenever you are managing or is trying to stabilize a trauma victim in your setting. So quick 10-second assessment क्या होती है in trauma patient? He tried to do but patient unresponsive था. What is that? Ask the patient name and ask what happened. So अगर कोई patient अपना नाम बता पा रहा हो तो इसका मतलब है कि उसका airway is intact. Airway is intact. अगर वो patient यानी A is intact, अगर वो patient अपना नाम बता पा रहा है तो it means is exhaling and producing a voice, which is mean that his breathing is still good. If he is rightly telling his name, which you can identify from the attendants, or he is telling you what was the event that happened, so it means that he has enough circulation in the system which is producing a good sensorium. So it means का C भी part सही है. और अगर वो correctly बता पा रहा है, then it means कि उसका neurological status is good, which is a D part in the ATLS protocol. And E in the trauma is, we will discuss in detail, is an exposure. He only exposed the chest. The 70% of the patient he never exposed. What were the injuries there? Maybe he had a bleeding femur fracture, which was the cause of hypotension, and he required to do a tight crab bandage, but he didn't do that. So he didn't expose the patient. He did not evaluate thoroughly the patient. So these 5 things, these were the things that are missing. So if the patient telling the name, it means that his airway, breathing, circulation and disability, they are intact, which is a good thing. But in the case scenario that we presented, unfortunately, that was totally an unresponsive victim where you had where you had a compromised airway, you had a problem with the breathing because he was desaturating, he was hypotensive, which means he was bleeding inside as well, and he had a poor neurological status. So all these things were there in this patient. So this is actually the primary survey, and we as a ATLS provider, as a trauma care provider, we all need to follow this. So in the airway, the good thing was that he was able to intubate it, but he never think about the C-spine, where the cervical spine was going. He was least bothered of that. That was a bad part in his demonstration. Breathing and ventilation, he never tried to auscultate even the patient, which was missing in that. Circulation and hemorrhage control, he think, like in our demonstration, he think that he may be bleeding inside the chest, but it was not there. So airway, whenever you are assessing the airway, you have to control the C-spine. When you are going to breathing, you have to see that whether the gas exchange is adequate or not. So breathing goes with the ventilation. C is circulation, so means heart rate, blood pressure, but you need to think that whether the patient is bleeding inside or outside. So patient may bleed in the chest, maybe abdomen, maybe in the pelvis, or maybe on the floor. Okay? So these things that you need to follow when you are doing the primary survey. So D is disability. The disability is always a neurological disability. People often think that it's maybe a muscular disability, maybe having a fracture. So वो जब report कर रहे होते हैं, so yes, he has D positive because he has the right femur fracture. The fractures or orthopedic deformity has nothing to do with the D in the primary survey. It's all about a neurological disability. Whatever the victim has neurological disability. Maybe you need to assess with the GCS or the pupils, but we will go in detail and we'll see how we actually perform. And E is the exposure and environmental control. So he also was not careful for the environment as well. So you need to think that your patient does not go hypothermic. This is a very important thing that you need to keep in mind. So primary survey, when A, airway and C-spine, breathing and ventilation, circulation and hemorrhage control. D stands for disability and E stands for exposure and the environmental control. So this is very important. Airway, establish a patent airway. So there should be a no blockage right through the nasal cavity or oral cavity up to the trachea or tracheobronchial tree. So there should be a complete patent airway. And whenever you are managing the airway, your C-spine should always be protected. Because lots of times what happens that smaller injury, maybe an incomplete cord injury, may turn into a complete cord injury after your resuscitation. Because that happens when you don't protect the C-spine. So establish a patent airway and protect the C-spine. This is a very fundamental part. Breathing, adequate oxygenation and ventilation. So you need to think, bhai, oxygen adequate ja rahi hai, nahi ja rahi, what are the respiratory rate? This patient was tachypneic up to 40, then jumped to 48. So you need to think what are the respiratory rates, chest movements, whether they are present or absent, air entry, you need to think about auscultation, and then oxygen saturation, which will tell you that how the breathing and ventilation is going on. So in breathing part, you have to take care all of these things. Circulation, that means hemorrhage control. Patient there may be a occult bleeding or there may be an obvious bleeding. So obvious bleeding may be from the scalp can bleed a lot. There may be a concealed hemorrhage inside the chest cavity, there may be a bleed in the abdomen, there may be a bleed in the pelvis. Even the femur fracture can bleed up to the 1 to 1.5 liters. So are the tibia fractures. So you need to think about that whether there is ongoing hemorrhage or not. So if you can control it with the dressing, or you need some sort of advanced technologies, maybe you need to angioembolize. But these things you should be in your mind. In our demonstration, that was not, because if it was in the mind, then the demonstrator must have ordered maybe a FAST to see whether he is bleeding inside or not, maybe a pelvis X-ray to see whether there are pelvic fractures that can be a source of bleeding. So you need to think about whether your patient is bleeding or not. And then what is important is the organ perfusion. Organ perfusion, you can check with the urine outputs. If your patient is alert, the sensorium will tell you that whether the circulation is adequate or not. Disability is assessed the GCS. In our demonstration, the GCS was not performed, could have been performed, should have been performed in fact. But the GCS, we all know that we see the eye response, verbal response, motor response, and if your patient GCS is very low, maybe less than 8, then it's classified as a severe head injury, and this is the area where you need to intubate your patient. Pupil reflexes were not checked, but in the disability part, you need to check your pupil reflex as well. So again, the disability is always a neurological disability. It has nothing to do with your orthopedic disability. So you need to check only the GCS and the pupils. And then exposure. You have to completely undress the patient, and what is important is the log roll of the patient. So 50% of the patient is front, 50% of the patient is the back. So unless you don't see the back, you may be able to miss lots of injuries inside the back. Maybe there are penetrating wounds, maybe a stepping of the spine, maybe a hemorrhage, whatever it is. But you have to log roll the patient, and we will demonstrate what is the correct way of the log roll, and then we will do in the second demonstration as well. Very important is that whenever you are exposing your trauma victim, whatever the circumstances are, whatever the emergency service you have available, always try to prevent hypothermia. So if the weather is of winter season, maybe the warm saline, blankets, turning off your AC, switching off your fans. So this is a very important thing whenever you expose the patient. So completely undress, log roll, and prevent hypothermia. And whenever you are doing this A, B, C, D, E, whenever you are doing with A, B, C, D, E, you have to perform some adjuncts as well. In the primary survey, there are several adjuncts which are very important. In our demonstrator only asked for BP cuff, but there are the pulse, the oximeter, you need to check an ABGs, vital signs, ECG, urine outputs, and also the need for urinary catheter, gastric catheters. These are very important things that you need to place. So whenever you are doing the primary survey, ask for these tests. Maybe whenever you are putting a cannula to run the fluids, ask your nurse to take the blood sample. And this blood sample can go for baseline labs, coagulation, etc. And also it can be used for cross-match. The second thing is that ECG is very important, and the two catheters should always be passed while you are doing the primary survey. One is a gastric catheter, one is a urinary catheter. I'm not calling it NG tube, nasogastric catheter. Anyone knows the reason why I'm not calling it NG tube, why I'm calling gastric catheter in the trauma setting? Yes. So maybe the victim has a severe head injury, so NG becomes the contraindicated. And I'm not calling it a Foley's traditional catheter, I'm calling it a urinary catheter. That's good. Same is the reason. So there may be a penile injury or urethral injury, which may be a contraindication for passing a Foley's traditional Foley's catheter. And in this setting, you need to pass a suprapubic catheter. So these are the adjuncts when you are doing airway, breathing, circulation, disability, and exposure. So if you have a big team, you can do it horizontally as well. If you are alone and with the nurses, then you have to do in a sequential order. So it means that अगर आपके पास लोग हैं ज़्यादा, तो आप जब एयर मेंटेन कर रहे हैं तो अपनी नर्स को कह दें कि भाई आप वो दो कैनुलास लगाएं, आईवी लार्ज बोर आईवी कैनुलास लगाएं, फ्लूइड्स दें, सैंपल्स लें. दूसरे को कह दें ECG लगाएं, and that someone can take care of the urinary and gastric catheters. So if it's going in the horizontal way, then you can distribute the task. If it's going in the vertical fashion, then you have to do all by sequence. That is airway and C-spine control, breathing and ventilation, circulation and hemorrhage control, and D stand for disability, that means the neurological disability and environmental control. And meanwhile, you must have ordered the test, baseline test, you must have passed these catheters, because these include the adjuncts to primary survey. You don't need to wait for the secondary survey for it. So there are some x-rays as well. Adjuncts to primary survey, they include only two x-rays, the chest x-ray and the pelvis x-ray. Most of the people think that this includes C-spine x-ray as well. The C-spine x-ray as well. So it does not include the C-spine x-ray. So the two orders that you need to order, chest x-ray and the pelvis x-ray. This will tell you whether there is a hemothorax or not, whether pneumothorax or not, you require a chest tube intubation or not, and then a pelvis x-ray, because this your hypotensive patient may be bleeding through a fractured pelvis. So you need to take care of all these things as well. And beside the chest x-ray and fast pelvis x-ray, what includes is the performing of FAST as well. FAST as well. So FAST is focused abdominal sonography in trauma. Here we see actually the four parts. What we see the pericardium, that is there may be a pericardial effusion or that causing the tamponade, which may be a cause of hypotension as well. And if you don't treat the tamponade, your hypotension will not settle with the IV fluids, with the blood, because the heart is unable to pump. So you need to think about it that this hypotensive patient may be because of the pericardial tamponade as well. What else we see is the Morrison pouch, a space between the liver and the right kidney. There may be a blood that can be an indication that there is a severe liver injury. Then similarly, space between the spleen and the left kidney, splenorenal space. This is area, potential space where the blood or a fluid, which can be a bowel content, can be there. And then you have to see a suprapubic space as well for the fluid as well. DPL, people say that it's contraindicated, it's not being done. It's in the ATLS guidelines, it is not contraindicated, it should be done. But whenever you are, the places where you don't have FAST. So if you have FAST, because FAST is a non-invasive test, cheaply available, readily performed, so, and there is a less chance of inadvertent injury. So whenever the setting, where you have FAST, perform a FAST. If you don't have a FAST, perform a DPL. DPL is basically a diagnostic peritoneal lavage, where you have to insert a needle below the umbilicus. You make a small cut under local anesthesia. You pass dialysis catheter, peritoneal dialysis catheter, and then you lavage the whole cavity with a 1 liter of fluid. And then you see what the contents of this lavage are. So there are some points where your DPL is positive, and which we all need to know. But DPL should be done if FAST is not available. These are the modalities which will tell you that whether there is an free intraperitoneal fluid or not. Yeah, EFAST. EFAST is a fast where you can actually see the lower thoracic cavity as well, because that will tell you that whether there is a pneumothorax or not. So EFAST is being encouraged, but in the latest guidelines, it's not. Yes, EFAST, FAST can be changed into EFAST just to see that whether there is a pneumothorax in the bilateral chest or not. So whenever you are resuscitating a trauma patient, very important is that to re-evaluate the patient. So what you can do is high flow oxygen, 2 large bore IV cannulas, you give the fluids. So when you are giving the fluids, what you need to see that whether the patient is responsive or not. And there are many things which you can do when you are passing your IV lines. You can get the samples for the blood. You can check. You can take a sample for the cross match. What you can do is give an antibiotics if it's indicated, and the tetanus prophylaxis you should do when you are managing your lines. Analgesics very important, especially it's very important when the patient is responsive, is alert oriented. But what is more important is try to re-evaluate your patient. Whatever the intervention you have done is to re-evaluate. Unless you don't re-evaluate, you can't think that whether your diagnosis was right or wrong. Because if a hemorrhagic patient is hypotensive, if you have a hypotensive patient and you are giving the fluid, but you don't re-evaluate, then you can't think that this is not a kind of hemorrhagic shock. There may be a spinal injury, the patient is having a neurogenic shock. So what is important is that neurogenic is try to re-evaluate. Whatever the intervention is, what sort of intervention is, try to see the response. The demonstrator was not keen to find out what was the response of his intervention. So he did a couple of interventions, he was not bothered of that. So you have nurses, you have already placed BP cuff, you have placed a saturation probe, you have put in a urinary catheter, you have placed a gastric catheter. Try to get the result of that. कि भाई gastric catheter डाला उसमें से क्या आ रहा है? Blood तो नहीं आ रहा. Urinary catheter डाला उसमें क्या blood तो नहीं आ रहा है? Urine कितना आया? ठीक है. ये whatever the intervention is in the trauma setting, unless you are not re-evaluating the patient, you can't manage the patient. So whatever the intervention is, you have to re-evaluate continuously, re-evaluate the patient. So now we will quickly go through the video demonstration. That it will be actually showing how the primary survey should be done, and we will try to follow in our previous dictum as well.
So Tracy, what do we got coming in?
Dr. Boyer sounds pretty sick. He's an 18-year-old motor vehicle crash victim, unrestrained driver. Sounds like he's a little unstable in the field. Heart rate is in the 120s, blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint. He's backboarded, collared. They have him on some oxygen. It sounds like his O2 sats are in the 88 to 93%, and his GCS is poor.
So minimally responsive, and they've got some oxygen going.
They have oxygen.
One IV?
One IV, I think 18 in the right AC.
All right. So it sounds like this guy is pretty injured. We're going to need to take care of a lot of things. It sounds like he has an airway problem. It sounds like he's in shock. So a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like you need to be intubated. So we got everything we need?
I got everything else.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put a second IV in on his other side that he doesn't have one. We'll get some blood out of that when we do it. Also, if you would call the lab and x-ray before he gets here, make sure they come and help us out. And Tracy, when he gets here also, I'm going to look at his airway, and while I'm doing that, can you put him on a monitor and a blood pressure cuff? And let me know immediately what the vital signs are so we can go from there. And I guess the other thing we want to think about is this guy's probably bleeding a fair amount from the sounds of it, so let's notify the blood bank, and let's get the massive transfusion protocol on standby and make sure that we got that ready to go. Also sounds like this guy is a little too sick for us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to him and get him transferred, okay?
Yes, sir.
All right. Any questions?
No.
All right, let's do it.
This is Garrett. He's 18 years old. He's an unrestrained driver in a single vehicle MBA into a tree. About 10-minute extrication. He has a GCS of about 8. Has a head injury up here underneath the gauze and has an open femur fracture with some minor bleeding.
Is it motor vehicle collision into a tree?
Yes.
Prolonged extrication.
10 minutes.
He's unrestrained.
Unrestrained.
And you said he's got an obvious head injury
Obvious head injury.
and an obvious femur fracture.
Open femur fracture with some
Okay,
bleeding.
and that's all you see right now.
The bruising to the left chest as well.
And his last set of vitals.
Blood pressure is 90 by Pal. He was 120 times tap on the monitor. Respiratory rate was about 12. Respiratory bilaterally. And he's unresponsive for us.
Any other issues?
Not that I know of.
All right, thank you very much.
Thank you.
All right, guys, this guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We'll start with the ABCs. So Tracy, while I'm assessing the airway, I want you to put some leads on. Let's get a blood pressure. And Betsy, if you can come over here on this side and help me with the airway. Looks like he's breathing about 20 times a minute. Sir, can you open your eyes? Sir, what's your name? Looks like he's not responsive at the moment. He's got some obvious facial trauma. And it looks like he's not breathing real well. He's a little bit blue.
O2 82%.
O2 sat's 82%, so we're going to need to intubate him. So what I would like you to do, Betsy, is I want you to hold C-spine precautions here. I'm going to take the C-spine collar off. And I'm going to put in an oral airway in here. See if we can get a little bit better. All right, let's put this oral airway in. Let's go ahead and bag him here. Responsive. It looks like he's going to need to be intubated. Do we have our intubation stuff ready?
Everything's right behind you, ready to go.
All right. Can you bag him here while I grab that?
I got it.
Can you come off for a second? Let me just take a look here. Looks like we got a little bit of blood in there. Let me suck that out. All right.
Suction.
Suction. All right. Good. Great. All right. Let me just take a peek here.
Let me know if you want some cricoid, Dr. Boyd.
Yeah, a little cricoid pressure would be great. Thank you. All right. See his cords. Tubes going in. Great.
Good color change. Good
Right.
color change.
All right, let's get him hooked up to a ventilator. In the meantime, let's put the C-spine collar back on, protect the C-spine. All right, and let me take a listen to his lungs. Betsy, there's a little bit of bleeding there. Put some pressure on that if you would.
Can we call for respiratory and a ventilator, please?
I got good breath sounds on both sides, a little bit less on the left and the right. He's got some bruising on his left chest. So let's see what we got. His airway is taken. We've got him as intubated. His pulse ox has come up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure is 90 over 42.
All right. So it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he bleeding anywhere actively? So he's bleeding down here on the leg. Can we get some more help? Hey, Will, can you help us?
Yep, come on.
Dr. Boyer, would you like a second IV?
Yes, let's start a second large bore IV, and let's hang normal saline. And how much IV is hopefully? Put some pressure on that if you would, please. You keep bagging. Start a second IV over here, Tracy, if you would. And I think this guy's going to need some blood, so let's call the blood bank and get a massive transfusion protocol going.
Okay.
All right, so we got control of the bleeding there, control of the bleeding there. Let me feel his pulses down here. I think his traction splint seems to be working. I think he's got good pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis is not stable. I think he's got a pelvic fracture, so you could have significant bleeding from there. So definitely this guy's going to need some blood, so let's make sure we get some blood products for him. In the meantime, let's expose the patient. Is that bleeding seem to be taken care of there as you wrap that, Will?
Yep, looks pretty good now.
All right, can you go ahead and get him exposed, take off the rest of his clothes there? And once we get him exposed, let's make sure we get some warm blankets to cover him back up so we don't get hypothermic. Let's do a disability exam. All right, sir, can you open your eyes?
Blood is running.
He opens his eyes to pain, that's a 2. Wasn't verbalizing, so that was a 1. Let me see if he responds to painful stimuli. Well, he's localizing, so that's a 4. Guy looks like he's got a significant head injury, and we're going to need to get him to a neurosurgeon. In the meantime, let's keep oxygenating him. What's his blood pressure doing now? Looks like, let's see, it's up to 105 systolic. Heart rate's down to 100. We also, I think we're going to need to wrap this pelvis with a sheet. Can you grab a sheet for me there, Will? Let's go ahead and make sure we wrap this pelvis. And we're going to need to log roll him. So we got him hooked to a ventilator.
Coming up.
All right, this is going to be on your count. You count it down for us on the count of 3.
Secure 1, 2, and 3.
All right, let me get this backboard out.
Watch the IV.
And I'm going to examine the spine here to make sure there's no step off. Feels like there's no step off here. Let's do a rectal exam. I need some jelly for that. All right. All right. He's got good rectal tone. Well, I've got him up here on the side. Let's put the x-ray plates in to get a chest and a pelvic x-ray.
Watch the IV, sir.
All right. And let's bring it back on your count again.
Ready? 1, 2, and 3. And 1 more.
Can we call for x-ray, please? All right, we'd like a chest and a pelvis.
Yes, sir.
All right, guys, let's reassess what we've done so far. We've done our ABCs. We've got him his airway control. We've assessed his breathing. He's got good breath sounds, a little bit of diminishment on the left-hand side. We know that he has a pelvic fracture and some bleeding from an open femur fracture. We've reduced that. We've got good pulses. He's also got some bleeding from his scalp and an obvious head injury. So this guy, clearly, we need to transfer him to a trauma center. So what I'd like to do at this juncture is we'll take a look at those x-rays we shot. I want you to put an OG tube in because of concern for a head injury, and I want you to put a Foley catheter in a moment here. And then what we'll do is reassess the patient. What are his vital signs right now?
Currently, his O2 sat is 96%. His blood pressure is 110/64. Heart rate is 97.
And we've given him how much fluids?
500 cc's of saline and 1 unit of Pac, 2 units Paxil.
2 units Paxil and 500 cc saline. So it sounds like we've stabilized him a little bit. We've got a sheet around his pelvis here. We're going to get him packaged up for the trauma center. So Betsy, could you get the trauma center on the phone for me? I need to talk to them and arrange transport. And while we're doing that, we're going to do a detailed secondary survey. We're going to do a head-to-toe, fingers and tubes in every orifice exam. We'll get him all packaged up to go. And also, Betsy, could you make sure that the X-ray department makes copies of all of our X-rays so we can send them along? Tracy, it looks like we've got our X-rays back. We got a chest here. Looks like he's got some rib fractures here on the left side and some haziness. He's probably got a pulmonary contusion. And his pelvic film, he's got a acetabular fracture, a pelvic fracture. That confirms, I think, what we think is going on with his blood loss. Let's get copies of these X-rays made and send them so we can send them on to the next hospital with him, okay? Dr. Brazell, hi, this is Mark Boyer from Mary Washington. I got a patient that I need to transfer you to. It's a 18-year-old young male who was involved in a high-speed motor vehicle collision. He ran his car off the road into a tree. There was significant damage to the front end of the car. He was unrestrained. Apparently, he was unresponsive at the scene. We intubated him. He does have some diminished breath sounds on the left side with some rib fractures, and also he's also got what appears to be a pulmonary contusion. He's also got bleeding from a scalp wound. He's got an open femur fracture on the left side. We've immobilized it. He's also got a pelvic fracture. We've got him in a pelvic sling right now. We've given him 2 liters of fluid. He's got 2 units of blood. His blood pressure right now is 110/50. His heart rate is 110. And we've got him intubated on 100% oxygen with 98% saturation. Yeah, I think that he probably needs to come by air.
So if we can make the arrangements to send the helicopter, I'd appreciate it. And I will package him up. I'll send some blood products and we'll send the x-rays as well. And we'll await your arrival. In the meantime, I'll get some x-rays of his femur and everything else, but we won't delay his transport. Any other questions? No? Thanks. Thank you very much.
So here we actually see the Mark Walter, who was actually a ATLS provider in the rural health or maybe a primary care center. He had some facilities, but not the kind of advanced facilities. He did not have neurosurgeon available there. He did not have a cardiothoracic surgeon available who could take care of his injuries, and he did not have orthopedic surgeon there. But he actually was managed to stabilize the patient. This patient, to begin with, was very sick, was very severe. So what he was able to manage, he was able to actually stabilize the patient so that he can arrange an air ambulance for that, and he can sustain the journey till the patient arrives in the trauma center. He was also able to manage. He also the best thing was Dr. Mark was that he prioritized the injuries. He did proper evaluation in the proper sequence. That is, his major intention was to go to the airway. He catched the airway at the first time, so he did think. Even when he was given the pre-hospital numbers, he was able to get that this patient may not be able to maintain an airway. So he was telling his colleagues that please arrange the stuff for endotracheal intubation. This patient may require the intubation. So he was able to prioritize and then was managing the things in a proper sequence. And the sequence is that he maintained the airway with a good control on the C-spine. He was himself controlling the C-spine. Then he was able to maintain a good breathing and ventilation. He did things for circulation. This patient was hypotensive. He gave him fluids, activated the massive transfusion protocol, activated the blood bank, and also ordered the fast, because he wanted to know that what is actually the cause of this hypotension, whether this patient is bleeding or not. He splinted the leg. He knew that there may be an orthopedic injury as well. In the disability part, he actually checked the GCS, he checked the pupillary reflexes, and he completely exposed the patient. And he also did the log roll. Log roll is very important because this is the point where actually you see the rest of the 50% of the body. So if you don't do a good log roll, you can miss the other injuries as well. So the mark point was prioritizing the things and following the sequence. What was also important, that he knew that his center would not be able to provide the definite care. To start with, he was quickly going, the thing was that was going in his mind that I will not be able to manage all the injuries. I need to check, I need to be contacted with the trauma center where these injuries can be ordered. So he was actually thinking on that there is always a need to transfer this patient. So when you are working in a center, when you can't provide a definite care, always thinking when you are doing your primary survey, when you are managing your airway, breathing, circulation, disability, and you are exposing and checking the injuries and resuscitating the patient, think for that whether I will be able to completely manage this patient or not, I need to transfer this patient or not. This is very important, and that's what Dr. Mark did. The second thing, the last thing that he did good also, that he communicated well. He communicated well, not only communicated well, but whatever the investigation, the results he had, he wanted to send the films with the patient. This is very important. So till the stop that he made, he wanted to the next center to continue from that. And he was also telling that he will be transferring this patient through the air ambulance and the service that he will be providing, what sort of services he will be providing. So whenever your trauma victim comes in, so the important thing is that the first you have to go to their airway. So if you don't secure the airway, your patient will be no more. You think that the patient is hypotensive, but he needs an intubation, intubation comes first. Of course, if there is an obvious hemorrhage, arterial sputter, you can do a bandage there. But Hypertension comes second. Even if your patient doesn't have GCS, but you need an advanced airway, try to secure airway first. Disability or a low GCS has nothing to do with it, with the overall outcome. It has output on outcomes, effect on overall outcomes, but if you miss the airway, you miss the opportunity. So whenever there is a need that you think that the patient airway is not intact, you have to intubate, you have to secure the airway. I'm calling it secure the airway. So secure the airway, whatever that's, and give a good oxygenation. So just to start with, till you arrange your stuffs, what you can do, कि भाई oxygen mask लगा दिया, and every trauma patient gets 15 liters of oxygen. Not 2 liters, not 5 liters, not 10 liters. The ATLS guidelines says that every trauma victim should get a face mask with a 15 liters of oxygen. So आप airway से पहले जब तक आप supplemental oxygen दें, you can do a suctioning, you can place a oral airway, and then if you think that this patient requires an advanced airway, then you need to put a endotracheal tube. For this, the center must have laryngoscope and the necessary stuff for the oral airway. So this is very important. Then in some settings of the trauma, when you are not able to do an ETT, pass an ETT, maybe the patient is having a severe facial fractures, maybe the patient is a victim of burns, or where you have a blood and you can't visualize, then you need to think that you can do some sort of other airways. That is, do not go through the oral airway, you need to do a cricothyroidotomy. That is, you have to pierce the cricothyroid membrane, maybe to start with the help of needle. That is called needle cricothyroidotomy. You just palpate the cricoid cartilage, thyroid cartilage, and in between them you can insert a needle and you can attach with the oxygen source. This needle cricothyroidotomy can actually give you a time of 45 minutes till you arrange a stuff for a tracheostomy or a surgical cricothyroidotomy. So this is very important. Airway comes first. So once you have secured an airway, see what's the response. Always check the response, and then go to the breathing, and in the breathing you have to completely inspect the chest. Yes, our demonstrator did that. He was able to pick that there was a large bruise, and he related that there may be an associated hemothorax in the patient as well. So you have to inspect the chest, you have to palpate the chest, you have to auscultate the chest, and you have to percuss the chest. And also the neck should be stabilized whenever you are doing this stuff. In the neck, you have to check whether the trachea centrally plays or not, because there may be a life-threatening situation when the trachea are diverted and deviated. These are tension pneumothorax. So these are the things that you need to take care. And in the circulation, of course, you have to pass the 2 large IV board cannulas, give the fluids, activate the multiple transfusion protocols, whatever the system of in your hospital, and then arrange the fast. In the fast, you can check that whether the patient is bleeding inside or not. So this is very important. So fast is a part of primary survey. Whenever you are checking A, B, C, D, E, order the fast. Activate your radiology that we need a fast on this trauma victim. We need to find out where the source of bleeding is. So this is, if you don't have fast, an alternative is the DPL. And then the second part, the fourth is disability. Of course, disability means that you have to check the GCS. GCS means that EMV, we all know. Just to recall, कि आप पेशेंट को पहले पूछें कि भाई आँख खोलें, अगर वो खोल रहा है spontaneous, then it's already 4, not, then give pain, and then see if even it's not pain, then you can call it 1. So in the same way, verbal, motor response you have to calculate, and see the pupils as well. So correct GCS, correct pupils, ये देखने हैं. And then last important, very important, is the log roll. Log roll actually is very important because it tells you the remaining of the 50%. Can you come please? So we will demonstrate what is the good way of log roll. Because patient is 50% back. So we have one person who will be controlling the C-spine. Maybe Dr. Noman, you can control the C-spine. And when you are controlling the C-spine, so your hand should be behind the scapula. The whole neck should be held with the help of forearm. And then you have 2 assistants. One will be place his hand at the shoulder, one at the pelvis, and the next will cross it. And these will be at the ankles. And the person who is on the neck side will be actually giving the command. On his command, the patient will be log rolled. On any direction, patient can be log rolled. In our patient, there was an associated right femur fracture. So ideally, is that patient should be log rolled on the left side. So in every trauma victim, the patient should be log rolled. Before that, you have to completely expose the patient. You have to completely undress the patient. And the person who is on the neck will give 2 commands. First, he will count 1, 2, 3. And he will tell that on which side of the patient he has to log roll. So he will be giving 1, 2, 3 log roll on the left side. And then the 4th person, which is actually the assessor, he will be actually assessing the rest of the 50% of the patient, which is the back of the patient. And when you are assessing the patient, what you are thinking? Obvious wounds, sites of bleeding, maybe stepping of the spine. And last but very important is to the DRE. In the DRE, you need to check that whether the tone is intact or not, because a lax tone may be a sign of spinal injury, or there may be a high riding prostate, which is a sign of urethral injury. So these are very important. And similarly, when the patient will be tilted back after doing a successful log roll, it will be on his command, the person who is controlling the C-spine. So Dr. Oman, ready हैं आप? आपकी count पर 1, 2, 3 आप कहेंगे. Okay. So he has correctly log roll. What I am doing is just inspecting the whole of the back, trying to see the spine, trying to palpate the C-spine. I had a collar, so beneath the collar, I'm palpating the spine. I'm checking any stepping. There is no stepping. So if the patient is alert, so they can you can always check for tenderness. So then I will be doing a DRE, and I will be assessing the tone and also the level of the prostate. And now I have done the log roll. I have inspect. अब ये है कि अगर आपने chest X-ray और pelvis X-ray करने हैं, ideally the films should be placed at that time. This is the ideal time when you can place your chest X-ray films or pelvis X-ray films. आप उसी वक्त chest X-ray की film रख दें, X-ray pelvis की रख दें. No C-spine X-ray. In ATLS guidelines, there is no C-spine X-ray. So if you have to rule out the C-spine, maybe when you are ordering the head CT scan, you can order a CT scan head. So only 2 X-rays are included in the ATLS guidelines. So आपकी count पर patient वापस आएगा. So patient is back on it. So if the patient had a spine board, you can remove the spine board just at the time of log roll. So these are the 2 opportunities from the log roll that you can do it when you are performing a log roll. So this is the way by which you can do a log roll, and this is very important, and it comes in the E part, exposure part. So what is important is that we all need to know these are the basic skills that we need to know. Whenever you are working in a, maybe a primary health care or a secondary health care or a rural health center, and you don't have facilities, but these are actually the basics, fundamentals. Because if you don't perform this, even a single step can make a big difference on the overall outcome of the patient. But if you have these things in mind, then you can only perform it. Is that airway? Airway क्या क्या है कि भाई chin lift and jaw thrust, oral or nasal airway, endotracheal intubation, needle cricothyroidotomy, endotracheal tube, or a surgical cricothyroidotomy or tracheostomy. So very easily we can do it. Chin lift and jaw thrust is just because this helps you. चल नहीं रहा. Because this helps you कि आपका airway कहीं से block तो नहीं है. So you can simply chin lift the patient and you can do a jaw thrust. So opening the airway. कोई fall of tongue ना हो. फिर आप उसके oral airway डाल सकते हैं. Meanwhile you are arranging stuff for endotracheal intubation. So these are the procedures when you are unable to perform endotracheal intubation, because facial fractures हैं, कुछ नज़र नहीं आ रहा, अब क्या करना है? So what you can do is you can only do a needle cricothyroidotomy, and you can ventilate the patient with the help of these maneuvers up to 45 minutes. एक है ये 14 gauge का कैनोला, लेकिन अगर truly cricothyroid membrane से pierce करता हुआ airway के अंदर हो, you can attach this cannula with the oxygen source and you can ventilate this patient up to 45 minutes. Meanwhile, you can arrange stuff for the tracheostomy tube or a surgical cricothyroidotomy. So this is very important, a very simple maneuver. Just palpate the cricoid membrane, palpate the thyroid cartilage, take a cannula of 14 gauge, attach with it a syringe and pierce it through the cricothyroid membrane at an angle of 45 degrees. And once you are inside the trachea, once you are inside the airway, what you all need to do is just remove the stellate, attach the cannula with the oxygen source, and ventilate the patient up to 45 minutes. A simple maneuver, a life-saving maneuver, but a huge change in the overall outcome of the patient. So if you are trying to arrange the OR nahi hai, OR arrange karna hai, just pierce this cricothyroid membrane and ventilate the patient to the 45 minutes. Breathing, this is very important in trauma. So every trauma patient should always get 15 liters of oxygen. No rule, no formula, just attach a face mask and give 15 liters of oxygen. Two things that you all need to, if you have already secured an airway, but you are, if you have already secured an airway, but you don't have, your breathing is not adequate, or the patient saturation is not improving. Respiratory rate, saturation is still desaturating. So even after an airway, there may be a problem with this chest part. There may be a thoracic injury as well. And what is more devastating is, what more potentially life-threatening is, the patient may be having a tension pneumothorax. So even if you have a good airway, the patient at tension pneumothorax, your patient will not survive, will not make up if you don't diagnose it and if you don't correct it on time. Tension pneumothorax is a clinical diagnosis. It doesn't require an X-ray. So how you can diagnose the tension pneumothorax? Usually air is throughout in the thoracic cavity. You don't find the air movement. You don't find air entry, and there are no breath sounds. And associated to this is engorged neck veins on the ipsilateral side. What you have to do is relieving a tension pneumothorax is quite simple thing. Again, you have to use a 14 gauge cannula or a 16 gauge cannula, and you have to insert it into the second intercostal space in the mid clavicular line. Once it's in, just remove everything and try to escape, try to make sure that the air is actually escaped. And by this way, you can convert a tension pneumothorax into an open pneumothorax. And this is again a life-saving, just like a needle cricothyroidotomy. If you can diagnose a tension pneumothorax, and a simple cannula is actually a difference between a life and death. Often it becomes a difference between life and death. Once ever you have placed a needle inside the thoracic, needle thoracentesis, this should always be followed by chest tube. So this is very important. So needle thoracentesis for the tension pneumothorax and chest tube insertions, these are very important if you have a patent airway, but your patient is actually not ventilating well. So second intercostal space, just put a big 14 gauge or 16 gauge cannula and remove the stellate and make the tension pneumothorax to open pneumothorax. Chest tube insertion, most of the surgical people are familiar, but as an ATLS provider, we should know that it's generally put in the triangle of safety in the fifth intercostal space. In the comatose patient, you don't require a local anesthesia, but in a patient, you have to place a chest tube, and it's always attached with the underwater seal. Circulation, fast we have already talked about. DPL in the children, when you don't have an access, intraosseous cannula is an alternative way. In the tibia, you can place intraosseous cannula, but the correction of state of shock is very important. You have to recognize that there is a shock and how you can correct it. And whenever there is a shock, stop the bleeding. How can you do that? You can directly pressure the source. You can use angioembolization if you are working in an advanced trauma center. Reduce the pelvis. Don't need to apply a pelvic binder. Even a simple sheath can be enrolled along the side of trochanters, and you can apply a pelvic binder. Because once you apply a pelvic binder, that actually reduces the volume of the trauma. So pelvic binders are generally applied at the level of the log roll, and once it's tightened, so any open book fracture can be reduced. So the volume of the pelvis can be reduced, and there may be a less bleeding, ongoing bleeding. So this is very important, that you need to stop the bleeding. And of course, the fractures need to be splinted. Disability, you have to calculate the GCS and pupil reactions, and exposure, we have already done the log roll. Now, when you are doing a primary survey and you think that you are arranging a stuff for the transport and you have an ample time, you can do a secondary survey on your patients as well. So secondary survey में क्या होता है कि you have to take an ample history. History only includes 5 things in trauma: जो भी अटेंडेंट है उससे पूछना है कि भाई आपके पेशेंट को एलर्जी तो नहीं है कोई, आपके पेशेंट की मेडिकेशंस क्या हैं, आपके पेशेंट को शुगर ब्लड प्रेशर कोई बीमारी तो नहीं है, आपने के पेशेंट ने आखिरी खाना कब खाया था और ये इवेंट कैसे हुआ. बट रिमेंबर द हिस्ट्री कम्स इन द सेकेंडरी सर्वे. सो इन डीलिंग विद द ट्रॉमा पेशेंट्स ये नहीं है कि हम पेशेंट की हिस्ट्री लेने में इतना टाइम ज़ाया कर दें कि ना एयरवे सिक्योर हुआ, ना ब्रीथिंग सही हुई, ना सर्कुलेशन हुई. सो दिस इज़ वेरी इंपॉर्टेंट स्लाइड. So your history should be short and brief, comprehensive, and always come in the primary, in the secondary survey. When you are done with the primary survey, you have done with the adjuncts, you have ordered the chest X-ray, pelvis X-ray, and fast ultrasound. Then this ample history you have to do it. And then after that, even अगर ambulance आ रही है, transportation होनी है भी, और आपके पास time है तो आप secondary survey कर सकते हैं. And that secondary survey means complete head to toe examination from the scalp through the eyes, nose, ears, oral cavity, neck, chest, everything you will reassess. Even those things that you have already done in the primary survey, you have to go back and do it again. When you are doing the head to toe, GCS need to be calculated again. Again you have to calculate the pupils because I will come on your way. So everything that you have already done, secondary survey will repeat. In the secondary survey, you will repeat it, and it's a thorough examination. And then the CT scan. CT scans do not come in the primary survey, so they come in the secondary survey. कि head का scan कराना है, neck का scan कराना है. They in the ATLS guidelines, these come in the secondary survey. What important is resuscitate and reevaluate. This is very important. Even whatever the maneuvers you are doing, you have transfuse the blood while doing a secondary survey, see the response, whether the blood pressure going up or not, whatever the change in the outcome of the patient. Re-evaluation, so is very important. And then that need to transfer, never forget that. Never forget the need to transfer. प्राइमरी सर्वे में भी करना है, सेकेंडरी सर्वे का अगर आपको टाइम मिला है तब भी आपने ये सोचते रहना है कि भाई मैंने ट्रांसफ़र करना है, ये पेशेंट मेरे पास पूरा मैनेज नहीं होगा. बहुत छोटी सी वीडियो है, वी विल क्विकली सी. अगर आपके पास टाइम है, प्राइमरी सर्वे आपने कर लिया है एंड यू थिंक कि भाई इस पेशेंट को जब तक कि आप एम्बुलेंस आती है, शिफ्टिंग की बात करते हैं, सेकेंडरी सर्वे का टाइम है, देन यू कैन डू अ सेकेंडरी सर्वे ऑन द पेशेंट.
Done our adjuncts to the primary survey, gotten our x-rays, put our OG tube and our Foley catheter in. We're going to start the secondary survey. I'll start up here at the head. His left pupil is 5 millimeters and minimally reactive. Right pupil is 6 millimeters and reactive. He has obvious head trauma here with a laceration, soft tissue injury, and the left temporal frontal region over the forehead. There's no active bleeding at this moment right now. His nares are patent without any blood. Mid-face is stable. Mandible has no crepitus to it. I don't feel any crepitus about his face either. No cephalohematoma in the back. There is a mild cephalohematoma in the front here. Okay, let me take a look at the tympanic membranes. The left tympanic membrane has some hemotympanum. The right tympanic membrane is clear. Okay, I'm going to move down to the neck here. Mark, if I could get you to come and hold C-spine so I can look at his anterior neck and feel his C-spine. Hold C-spine for me.
Yes, ma'am.
Okay, I'm going to release the anterior portion of the collar. There are no anterior hematomas. No carotid bruits. I'm going to reach behind you here and take a feel. No gross cervical spine step-offs. Okay, Mark, I'm going to put the collar back on. Thank you. Moving down, his chest has a large amount of ecchymosis to the lower anterior left chest. There's a mild amount of crepitus there. No true subcutaneous emphysema. His lungs are clear, but there's a slightly decreased amount of breath sounds on the left-hand side there. His abdomen is soft, non-distended, His pelvis is wrapped with a pelvic sling. I'm not going to re-examine that. We already know it felt unstable. His flanks have no ecchymosis. Moving down. His pelvis is in a sling. I'm not going to re-examine that. We already know it's unstable, and I'll leave the sling in place. Moving on to his extremities, he has an obvious open deformity to the left femur, fracture deformity. The right extremity, I don't see any gross deformities on here. I'm not going to mobilize that left or right extremity because of the pelvic fracture. Looking at the other extremities here, no gross deformities on the upper extremities. Moving on to vascular. He has less than 2-second capillary refill in his bilateral toes. 1+ dorsalis pedis pulses in both feet. 1 to 2+ radial pulses in both arms. Overall, I don't see any other gross abnormalities. His urine is clear, so we are going to need x-rays of his left femur, left knee, left hip. We already have the chest, we already have the pelvis. And at this point, we also need to see where we are on locating or on contacting the transfer center. I'm going to cover him up to prevent hypothermia.
So this time, Jenny had a chance. So she did all the management. Sorry.
Question?
Yes. Okay. That's a good thing. What you have to do is your hands should come beneath this scapula, right? And these thumbs on the clavicle, and the whole forearm will be stabilizing the neck. In this way, you can stabilize the neck. This is the thing that you need to think, you need to do when you are passing the tube, when you are examining the neck, when you are doing the log roll. So every intervention that has a chance that can destabilize your neck, you have to properly stabilize the neck. So if you can do that. कर सकते हैं. Hand should come in, hand should come in this scapula, yes. And these forearms, this is the neck. By this way, you have to stabilize the neck, right? Okay. Right, अच्छा. आप आ जाएं. थोड़ा सा आगे हाथ पूरे स्कैपुला तक जाएंगे. फोर आर्म पे आपका नेक होगा जिस पे आप होल्ड करेंगे, राइट? सो दिस इज द करेक्ट वे ऑफ स्टेबलाइजिंग द नेक. इज दैट ओके? सो मेरा ख्याल आगे चलते हैं लास्ट पार्ट में. सो अब हम रीडेमोन्स्ट्रेशन करेंगे क्विकली उसी सिनेरियो की.
वालेकुम. अब हम रीडेमोन्स्ट्रेट करेंगे और मेरे पास डॉक्टर हैं, डॉक्टर साकिब ईआर में. डॉक्टर साकिब, एक अभी पेशेंट ट्रांसफर हो रहा है, सीरियस पेशेंट है, 30-year-old, RTA केस है, हेड ऑन collision, ejected from car, brought by 112. His vitals are heart rate 142, BP 90/60, yes, respiratory rate 40, and SpO2 88%. आपके साथ डॉक्टर अहमद होंगे एज असिस्टेंट.
गुड, ठीक है. तो डॉक्टर अहमद आप तैयार हैं कि हमारे पास एक पेशेंट आ रहा है जो कि बहुत सिक पेशेंट है, जिसको डबल टू ट्रांसपोर्ट करें हमारे पास. और जो बताया गया है वो ये कि पेशेंट हाइपोटेंसिव है, टैकीकार्डिक हो रहा है, डीसैलिड कर रहा है और ये पेशेंट अनरिस्पॉन्सिव है. तो सम सॉर्ट ऑफ हेड इंजरीज होंगी. आपको चाहिए कि आप मेरा अपना एयरवे देखें, जब एयरवे इसको मेंटेन करना पड़ेगा, एंडोडाइटिक तो वेल्स को हमारे पास प्रॉपर साइज होना चाहिए, और सेक्शन कैथेटर होना चाहिए, इसका ओरल कैथेटर होना चाहिए, हमारे पास आईवी बोर्ड कैनुला हो, हमारे पास ब्लड टैंक को इन्फॉर्म कर दीजिए, ब्लड एक्टिवेट हो जाए, हमारे पास रेडियोलॉजी वालों को बता दें हमें चेस्ट एक्सरे और पेल्विस के 2 एक्सरे चाहिए होंगे, हमें इस पर फास्ट करना पड़ेगा क्योंकि हमें नहीं पता कि ब्लीड कहाँ से कर रहा है। इसके अलावा और शायद हमें कॉन्टैक्ट करना पड़ेगा मे बी सम सॉर्ट हाई लेवल ट्रॉमा सेंटर में, क्योंकि शायद इसको डेफिनेट केयर की जरूरत पड़ेगी। ठीक है, तो सारे पेशेंट आ गए,
आप रेडी हैं सर?
जी सर हम रेडी,
पेशेंट
रेडी। तो हम यूनिवर्सल
पेशेंट आ गया सर,
दे देते हैं। So please switch off the ACs and वो चाहिए होंगे टेम्परेचर के लिए, ब्लैंकेट दे दीजिए।
एसी ऑन है, ब्लैंकेट दे दिया सर, बंद कर दिया।
आप सुन सकते हैं? बिल्कुल अनरिस्पॉन्सिव है, आप जब तक कि वो लगाइए सैचुरेशन प्रोब लगाइए, GT कफ लगाइए, आप मुझे वाइटल्स बताइए। इसकी ऑक्सीजन कितने पे है सर? 3 लीटर पर है,
5 पर लीटर
इसको 15 लीटर पे कर दें, ऑक्सीजन को 15 लीटर पे कर दें प्लीज।
कर दी।
क्या आपने सेक्शन कैथेटर मिलेगा? सेक्शन कैथेटर
सैचुरेशन इज ड्रॉपिंग, इट्स 85,
ओके,
now it's 80।
सेक्शन कैथेटर, सेक्शन कैथेटर ओ तो आप मुझे वो चाहिए होगा, मुझे इंटीमेट कर रहा होगा इसको, उससे पहले मेरे पास ओरल टेलीस्कोप दीजिए, साइज 7 ट्यूब दीजिए ताकि
जी सर, इट्स 90%।
आप एक काम कीजिए, आप दो कैमरास लगाइए और 2 लीटर डिस्टिल्ड फ्लूइड वार्म हो और साथ में अल्कोहल ब्लड भी दे दीजिए। मोबाइल में चेक देख लेता हूँ, लूज है, डिफॉर्मिटी नहीं है, क्या मुझे हॉस्पिटलाइजेशन के लिए स्टेप मिलेगा? और रेडियोलॉजी वालों को कॉल करें, हमें चेस्ट एक्सरे और पेल्विस का एक्सरे चाहिए होगा, हमें फास्ट भी चाहिए होगा। ही इज स्टिल अनरिस्पॉन्सिव। ऑस्कल्टेट कर लिया, राइट, सो स्टिल अनरिस्पॉन्सिव। कुछ बेहतर हुए वाइटल? तो सो हार्ट रेट बेहतर हो रहा है, ब्लड प्रेशर बेहतर हो रहे हैं, फ्लूइड्स हमने दे दिया, हमने 2 लीटर फ्लूइड चला गया, एंटीबायोटिक्स चले गई है, हमारा टेटनस लग गया है, हमने अनक्रॉस मैच एक ब्लड दे दिया है। मीनवाइल कोशिश कीजिए कि हमारा ट्रॉमा सेंटर से कहीं बात हो सके। मीनवाइल मैं जब तक मेरा टाइम है मैं डी फॉर डिसेबिलिटी देखता हूँ, GCS। आँख खोलिए प्लीज़, आँख नहीं, सो ही इज़ ओपनिंग द आइज ऑन द पेन, सो द 2 इज आई। हाथ उठा सकते हैं ये? नहीं, हाथ नहीं उठ रहा, कोई रिस्पॉन्स नहीं है, सो वेरी लो GCS, it's 4T/10 is GCS. So pupil मैं देख लेता हूँ, so it's bilaterally equally reactant to light, brisk pupil, right. So अब मुझे थोड़ा expose करना पड़ेगा, patient देखना पड़ेगा कि नीचे तो कोई obvious injuries नहीं है, his deformed thigh, so maybe a femur fracture, I need to splint that, splint arrange कर दीजिए please, splint arrange होगा, मुझे इसका पेशेंट का लॉग रोल करना पड़ेगा। डॉक्टर नुमान क्या मेरी हेल्प कर सकते हैं लॉग रोल के लिए? मैं पीछे से देखना चाहूँगा। सो व्हाट आर द इंजरीज? सो आई एम गोइंग टू टेंडरनेस, नो स्टेपिंग, नो ऑब्वियस पेनिट्रेटिंग वुंड्स, आई एम डूइंग द DRE, normal tone, normal prostate, back of the legs are okay to me. So you can do it back. वापस ले। So chest X-rays fast को कोई रिपोर्ट आई? सो फ्री फ्लूइड इन द राइट अपर क्वाड्रेंट, सो मे बी इसको लिवर इंजरी भी है. सो हम इस दौरान कंटिन्यू करते हैं, अपने सेकेंडरी सर्वे पर जाते हैं और आप कोशिश कीजिए कि मेरा कांटेक्ट करा सकें एक टर्शरी सेंटर में. चेस्ट एक्सरे की कोई डिटेल्स आई हैं? Right hemothorax. So I'll be needing a chest tube to place on the right side, and then I'll be needing an X-ray as well. So what I'm doing is that is in the triangle of safety in the 5th intercostal space, I will insert a chest tube. I don't need to place a local because this patient is already a comatose, and I will place the chest tube and connect in the underwater seal. So any improvement in the vitals? Good. Good. Such. So this patient has right hemothorax. We have placed the chest tube. We have maintained an airway. We have placed a tube. We have placed a chest tube. We have given 2 liters and along with a pack of blood. And this patient is not responsive. But I think, Dr. Noman, this patient will require a definite care, and for this we need to make contact with the trauma center because this patient is likely to have a head injury, severe head injury, and an associated thoracic injuries. So, कोई contact हुआ? Dr. Ahmad से बात हुई है? अस्सलाम वालेकुम डॉक्टर हमाद.
वालेकुम सलाम.
जी डॉक्टर साकिब बात कर रहा हूँ मैं.
ओके.
जी डॉक्टर हमाद, मेरे पास एक लड़का आया है जो कि RTA का विक्टिम है और काफ़ी सीवियर मल्टीपल इंजरीज हैं.
ठीक है.
सो बेसिकली इंसिडेंट ऐसे हुआ था कि ही वाज अनरिस्ट्रेन्ड ड्राइवर व्हेन ही हैड एन हेड ऑन कोलिजन विद द ट्रॉलर. उसके बाद ये इजेक्ट हो गया. इजेक्ट के बाद इसको डबल 2 लेकर आए थे. हमारे पास जब आया था तो काफ़ी सिक था ये.
ठीक है.
तो अनरिस्पॉन्सिव था. हमें ओरल एयरवे लेना था. हमने इसको इंट्यूबेट कर दिया. हाइपोटेंसिव था, टेकिकार्डिक था, 140 का हार्ट रेट चल रहा था, हाइपोटेंसिव था. हमने इसको 2 लीटर्स क्रिस्टोलाइड्स दिए. हमने इसको 1 पैक्सेल दिया है. टेटनस, एंटीबायोटिक्स, ये सारी चीज़ें हम कर चुके हैं.
ठीक है.
इनिशियली जो हमारी रिपोर्ट्स आई हैं उसमें है कि चेस्ट साइड में हीमोथोरैक्स थी. हमने इसके लिए चेस्ट ट्यूब डाल दिया. दैट हैज़ ड्रेन 200 ml ऑफ ब्लड्स. हमारा ख्याल है कि इसको न्यूरोसर्जिकल केयर की ज़रूरत होगी, इसको थोरेसिक सर्जन की ज़रूरत होगी और इसको प्रॉब्लली लिवर रेस्टोरेशन है और शायद इसको CT स्कैन, एब्डोमेन और GI सर्जन की भी ज़रूरत होगी.
ठीक है.
और हम यहाँ पे ये मैनेज नहीं कर सकेंगे, लेकिन हमारा ख्याल है कि हम आपकी तरफ भेज दें इस पेशेंट को ट्रांसफर.
ठीक है. तो आप किस वे ऑफ ट्रांसपोर्ट से इनको भेजेंगे?
सो हम इसको एम्बुलेंस के साथ भेजेंगे. हमारे साथ एक ट्रेन नर्स है.
ठीक है.
वो इनको बैग वेंटिलेशन करता रहेगा.
ठीक है.
ही इज वेरी गुड इन द IVs, मॉनिटरिंग द फ्लूइड्स, मॉनिटरिंग द रिस्पॉन्सेस. वो करता रहेगा. एक ब्लड हम एक और दे रहे हैं अनक्रॉस मैच. आपके साथ में चेस्ट एक्सरे, पोस्ट एक्सरे, चेस्ट ट्यूब के बाद का चेस्ट एक्सरे, पेल्विस एक्सरे और स्प्लिंट करके मैं भेजूंगा ये पेशेंट और उसके बाद आपको इनको डेफिनेट केयर करनी पड़ेगी.
ठीक है. कितनी देर में ये पहुंचेंगे मेरे पास?
आई थिंक वी आर एंटिसिपेटिंग दिस पेशेंट विल अराइव टू यू मे बी इन 1.5 hour. और लेकिन हमने इतना स्टेबलाइज कर दिया कि वी आर श्योर दैट आफ्टर गेटिंग एन एडवांस ट्रॉमा लाइफ सपोर्ट केयर ही विल बी एबल टू मेक द वे.
चलिए मैं अपनी टीम को रेडी कर लूंगा तब तक.
थैंक यू डॉक्टर हमाद. सो दिस वाज अ डेफिनेट ट्रांसफर टू डेफिनेट केयर. एनी क्वेश्चंस टिल नाउ?
मेरा ख्याल है कि इतनी लेबोरेटिव जो है वो उन्होंने दे दी है आपको, और मेरा ख्याल है कि इसमें जो टेक होम मैसेज जो है वो सिर्फ ये है कि जो भी आपके CNG का पेशेंट आए उसको आप वक्त पे उसको असेस करें और असेस करने के साथ साथ उसकी फिर सारे सिस्टम्स को देखने के बाद इसको अगर ट्रांसफ़र की ज़रूरत हो उसको ट्रांसफ़र करें. अब हम मेरे साकिब साहब का खास तौर पे जो कराची से हमारे पास तशरीफ़ लाए और बाकी सारी टीम का जिन्होंने बड़ा अच्छा यहाँ पे मैनेज किया, का शुक्रिया अदा करता हूँ. अब हाफ़ एन आवर के लिए वक्फ़ा है. इस वक्फ़े में आप चाय पी सकते हैं. कैफ़े में इंतज़ाम है ख़वातीन के लिए भी और मर्दों के लिए भी. आप टी ब्रेक है. ठीक 5:30 पर हम लोग यहाँ इंशाल्लाह पहले साइंटिफिक सेशन के लिए इकट्ठे होंगे. थैंक यू. जज़ाकल्लाह. मैंने करना बेहतरीन हो गया. चलो हम खाली कोशिश